resume our presentations for the first day of burn course sessions. Our presentation now is Care of the Burn Wound. It's presented by Justin Koehler. He is a RN on our PICU, has been doing it almost 15 years. He is not only a Bachelor of Science in Nursing, but a CCRN, or yes, which you would think means Critical Care RN, but it doesn't translate, but that's the gist of it. And then a CPN, Certified Pediatric Nurse. So something he's obviously very proud of, and we appreciate his support of our kids, their families, and us. And again, today he's going to teach us a little bit about care of the burn wound.
All right, thank you, Clayton. All right, as Clayton said, my name is Justin Koehler. I like to do wound care. I've been caring for burn wounds for close to 15 years, as he said. So this is a topic I really enjoy going over. All right, let's begin. All right, just before we get started, I might bring up some product information. I am by no means advocating to use specific products or being paid by anyone to use their products. It's just sometimes their habit to say their names, and I want people to be aware of that. Okay, by the end of this presentation, we're going to understand concepts of the initial burn wound assessment, be able to differentiate different kinds of burn wounds. We're going to be describing different treatments, different ways of caring for different types of burn wounds, and we're going to define the process to maximize function and ADLs after the treatment of the burn wounds. That process begins during initial treatment, believe it or not. Okay, initial management. Okay, so burn is a trauma. That's what people have to understand. It's a special kind of trauma. You can get severe burns, much less minor burns, but you always need to maintain your trauma protocols, airway and breathing, circulation, very important. You have to stabilize the patient first before you can treat the wound. And that's a whole other lecture coming up. Any other related traumas to the injury you need to look at. Fluid resuscitation is very important. And then, of course, anytime you have over 30% burn wound, you're going to go into hypermetabolism, which is a known thing that we've studied at Shriners for a long time. And that's real important to maintain proper nutrition. You want to keep their environment warm because they're going to have a difficult time maintaining body temperature, and they're going to lose body heat rapidly. And then you have to cover the wounds with something. Okay. So you're gonna manage small wounds. We do that all the time. Little minor injuries, we'll call them treat and streets. We basically treat them, send them home, and do follow-up care. And then larger burn wounds will usually stay in the ICU for an extended period of time. That could range from weeks to a year. We've had a couple of patients last a year and then walk out of our ICU, which has been great for us that we're able to do that. All right, so we'll start off with the easy one, first degree burn, which is also known as a superficial burn. The newer terminology is going to be superficial. This is just an epidermal injury. Basically, it's a sunburn. That's the easiest way to describe it. You're going to have redness. They are painful. Why? Because all your nerve endings are fully intact, right? So they hurt. They're going to blanch when you press on them, right? You're going to have blood flow. So you have not actually destroyed the blood flow to the area. So all superficial burns blanch. You can have some swelling, but you're not necessarily always going to have a lot of swelling. And these don't technically need a lot of treatment. These can usually just go away on their own with time. All right, you can put things on them to prevent the stinging. This is a good photo here. Sunburn, basically, is what we're seeing. All right. Now, on to more, also another thing to note, when you're doing a burn calculation, you do not calculate in first degree burns or superficial burns. They are not considered part of the burn percentage. You only start your burn percentage calculation when it comes to the partial thickness or second degree burns or worse. All right, so now we're getting into partial thickness, which is also previously known as second degree burns. All right, and you can have a multiple varying degrees, right? It's not just a partial thickness, you have varying degrees of partial thickness because you have a lot of dermal layer to go through. You can have superficial, you can have deep, and you can have some second degree or partial thickness burns that can also sometimes turn into a deeper burn. If they're not properly cared for quick enough, you'll lose the blood supply to the area and they become deeper. And I've seen that happen. So that's why it's important to treat them quickly and not let them deteriorate. All right, so you have your picture here of the epidermis. You're going to have burns into the dermal layer when it comes to the second degree or partial thickness burns, right? You can even go close to subcutaneous, but once you get down that deep, you're probably going closer to the third degree burn stage. All right. This is just basically another look at where different things are in your skin layers and what you're actually burning away when they're burned. So second degree burn, you can burn away the superficial layer of hair, but understand that your hair follicle is still there. Your hair will grow back, right? Things to keep in mind. Your sweat glands don't completely burn away. They'll grow back because you haven't fully destroyed them. But when you get deeper burns, you'll actually burn away your hair follicles and you won't grow hair in that area anymore, okay? That's when you get into the more third degree burn area. You can also tell that you have blood supplies here. And partial thickness burns, you're not burning away all of your blood supply, just the superficial, just the top layer, but you still have blood supply going in that area. If you go down deeper, you'll completely burn away your blood supply. That's why the tissue completely dies when you get deeper burns. All right, so we're going to assess a partial thickness burn. They are also very painful. Why? Nerve endings are still intact. You have not burned them away. They can present the more superficial second degree burns will show up as blisters, right? We've all seen them. You can get them from friction, right? Kids get them playing on the monkey bars, you have blisters on their fingers, right? That is a second degree burn, technically. Understand that the blisters, while intact after a burn, is sterile underneath the blister until that blister is popped. Once you've exposed the internal part of the blister to the outside environment, you now have a risk for infection. And this is what you want to be real careful about. It's a very small blister. We honestly recommend you just leave it alone. Let it heal in underneath. If it's a large blister, it's probably going to break very soon, and it might be best to clean that blister and then treat it. Partial thickness burns still should also blanch. Why? Because we haven't burned away the blood supply. It's still there. You should still have a blood supply to the area. All right, they're going to leak. They are going to be moist. More often than not, they will heal, and they will leave none to very minimal scarring. And that's an important thing to tell patients and parents, because they're going to start freaking out at this point. Oh my God, my kid's going to have a bunch of scars. Well, in this case, maybe not. Okay, we're not down to the third degree layer. Very minimal scarring, if any at all. All right, this is a nice picture of what the blisters look like on a larger burn area. Okay, and like I said, they're blisters. There's a fluid filling up those pockets of skin, and eventually your body will reabsorb that if they don't break, or they'll break open and leak out. Either way, it'll eventually go away. This is what happens when it's cleaned off. Just a pink layer. If you press on it, it'll blanch, and it is painful, so don't press on it too much. All right. Now we're going to look at the slightly deeper partial thickness or second degree burns. Now you're getting down, remember the picture of where the layers or where the nerve endings were and all that stuff. You're getting a little further down. You're going to cause a little bit of nerve ending damage here, okay? At this point, sometimes these don't actually hurt as much as the shallower burns. You'll have less pain involved with this because you can have some destruction of the nerve endings. Now your burns can start looking a little different. They're not going to be bright pink anymore. You can start getting a whitish or deeper red color, okay? Because you're getting closer to getting rid of the blood supply here. They don't tend to leak as much, but there's still partial thickness. There will be some exudate. There will be some leaking involved. Sometimes The deeper partial thickness are hard to differentiate between a 3rd degree burn. You'll notice a lot of times the physicians will give these deeper partial thickness burns time to heal and differentiate before they actually do full-blown surgery on the area, right? Do temporary coverage and see, let's see what it does. It's right there on the board. We're not sure which way it's gonna go. And sometimes they'll start to heal, sometimes they'll deteriorate to a deeper burn, okay? So I believe 2 weeks is the standard you give these burns to differentiate. And at that point, it'll be a surgeon's call on what to do with the burn, okay? And you'll see that a lot, do temporary coverage with xenograft, which is known as pigskin, until the burn differentiates. These tend to scar more because they're a little deeper, so just be aware of that. This is a picture of a slightly deeper partial thickness burn, and there's a chance it can heal completely on its own without surgical intervention. But if it gets infected or if it's improperly taken care of and dries out, it can get deeper and turn into a 3rd degree burn. All right. You notice there's some wider appearance here. It's might be hard to see on the overhead projection, but there's a little bit of a whitish appearance there in the middle and some deeper red areas. It's not just pink everywhere. All right, a little better picture here. This is probably a scald burn. Children will pull hot water down on themselves a lot of times and get scald burns. And they usually become partial thickness burns. All right, now we need to assess the 3rd degree burns, or full thickness burns as they're currently called now. So these are deep, all right, and these are not something you can just treat and send out, obviously. These are going to need surgical interventions. Usually anything greater than quarter size is going to have a hard time healing. Small areas, yeah, even small areas can heal on their own over time, but it takes a while because it's a very deep burn. This is anything past the dermal layer. It goes down into subcutaneous tissue, fat, or I've even seen them go as deep to muscle and bone. Okay, those are very, very deep. And at that point, you're definitely going to need surgical intervention to repair the burn injury. All right, you're not going to have hardly any sensation on these burns. That being said, they still hurt. Why? Because around the edges, you're going to have less burn, and that's where you're going to feel a lot of the pain. And over time, you will have some nerve endings regenerate, and they'll start hurting more later on than they do in the beginning. But if you press on these, they do not blanch. You have no blood supply left to the area. It has been burned too deep for blood to flow to the area. So these can appear many different ways. All right, white, also known as eschar, is going to be the most prominent of what you're going to see for a 3rd degree burn. It can also be brown, and it can just be charred looking. Extremely, extremely deep red sometimes can be another sign. And then obviously black is usually going to be a sign of necrotic tissue, where it's just burned so deep everything has blackened and taken all the color away. All right, you'll never really see a blister on a 3rd degree burn. It usually just turns into eschar. The skin turns leathery and rough, okay? And they're dry. They don't tend to have exudate either. All right, and here's a good photo of that. You can see the brownish areas, and then you can see a little mixture of some redder areas where it's not quite as deep, but those brown areas are all definitely 3rd degree burn. And then you can see some on the calf, maybe some wider areas where it's also deep. And this is a photo. You can actually see, looks like there was some eschorotomies done where the eschar was released on this patient. But that's going to help. Eschar turns leathery, right? So it's hard to breathe when your whole chest is leather and it has no expansion. So you do eschorotomies on chest when they're burned to allow the chest to expand, allow the patient to breathe, okay? All right, so calculating burns. Rule of 9s is a good one. This is the Lund-Browder chart. Very similar, but it breaks it down even further. I think this is the one we use more often in our hospital. But remember, 1st degree burns are not calculated in this. It's partial thickness, full thickness, or 2nd and 3rd degree burns only. All right, rule of 9 is what I was just speaking of, which is the easiest way to do it out in the field. You just remember, like, the front side of the arms, 9, back side's 9. You have the top and bottom of the leg is 9, and then the back side, top and bottom is 9. It's just 9s everywhere, and then your perineal area is 1%. And then remember, infants have a larger head compared to the body ratio of adults. So there's going to be more percentage on a baby's head than it is compared to an adult's. All right, so treating the acute burn wound. And this would be a quick overview of how you treat full thickness burns. You have to do surgical intervention, right? You can't just fix these with wound care. There's going to be wound care involved after the surgery, of course. You have to clean the burn wound. You have to remove the eschar. Eschar is dead tissue. You can't leave it there. And this is I don't know who's actually seen a burn surgery. They're pretty gruesome, especially the first one where you're removing all the eschar. Okay, it is one of the grosser surgeries you'll probably ever see. But you literally have to peel away the dead layer of tissue. And surgeons do that in surgery, under sedation, under anesthesia, obviously. There's a lot of blood loss involved in these surgeries as well, as you have to remove tissue to a viable layer, which is a layer that will bleed, right? So there's a lot of blood loss as well. We need to basically get to a good viable wound bed. That is a bed that will actually take a skin graft. If you put skin graft over eschar, it'll never take. There's no blood supply to allow that graft to live. So you remove the dead tissue, you get a good wound bed, and you can graft skin graft over that area that now has a good wound bed, good blood supply, and allow that graft to take. And that's how the general idea works. So postoperatively, on an acute burn wound with a full thickness burn surgery, you're going to have grafts, right? They're going to take tissue from non-burned areas of your skin. They're going to transplant them to the burned areas. And what we want is those areas that are transplanted to take and start healing in and become their skin in those areas, right? Well, they're going to be fragile at first. It takes time for those grafts to adhere. You don't want to put too tight of a dressing on. You don't want to put too loose of a dressing on. You don't want anything that's going to cause friction or shearing, because all that's going to prevent the graft from adhering where it needs to. Usually we're going to leave them in dressings postoperatively for 3 to 4 days, depending on the surgeon's discretion. So in the meantime, what do, right? You have a wound covered in dressings, you're just going to let it sit there for 3 to 4 days. Well, that screams infection to most people, right? You're not doing dressing changes. How do you prevent them from getting infected? We've found that soaks are a great way of doing this. We have medicated soaks. We can use silver nitrate, sulfamylon. There's lots of different medicated soaks. We literally just soak the dressings, soak the outer layers until they're moist for the first 3 to 4 days. And then during this time, we're also going to use splinting devices to hold proper body position, because we want the grafts to heal in proper position for function. So the arms, the hands, the feet, the knees, all these areas have splints placed on them if they're burned in those areas in order for the grafts to heal in proper position. All right, postoperative plan. So now we're sitting at day 3 or 4 post-surgery. What do you do with the burn wound, with the grafting that the surgeons have placed on the patient? Well, you're going to take the dressings down and get a look, right? And usually the grafts are held in by surgical staples, a lot of them. If it's a large area, you can have thousands of staples, and they can't just stay in the patient. You have to take them out, and that usually happens on day 3 to 4. It's kind of painful, so you're going to sedate the patient for this procedure. You can do a minor bedside sedation. That's what we normally do. We use ketamine. You can go back to the operating room under anesthesia and have it done there as well if it's an extremely large area as well. Sometimes the surgeons opt for that also. But during this time, the patient's sedated. You're taking the staples out of all the grafts that have been placed. You're assessing the wounds, seeing what grafts have taken, what have not. And then you're going to clean the patient. Running water, obviously, is the best way to do this, running water and soap. And we have special bath tables or tub tables that will clean them in after we removed all the staples. And then you're going to wait for those donor sites or the areas they removed the skin from to heal. It takes about a week, sometimes a little longer, sometimes a little quicker depending on the patient. And they can reharvest those same areas and graft again weekly until they've covered every burned area that needs to be covered with a skin graft. After day 4, usually you're going to do daily dressing changes until they go back to surgery again. Okay, and that's important because infection prevention. The last thing you want a burn wound to do is get infected. So we're real big on keeping our wounds clean. During the first 3 to 4 days, you're going to limit mobilization. Remember what I said, you don't want to shear the grafts. Any shearing force caused by movement can cause the graft to fail, especially grafts over joints. You bend your arm, bend your knee, you just cause a huge shearing force where that graft is. That's why they're splinted in proper position for 3 to 4 days. Also remember, over 30% you're hypermetabolic, you're going to have muscle loss, and all this with poor nutrition can factor into poor graft take as well. So nutrition and mobilization after day 4 are very important, but you usually have to wait a few days for that. For dressing changes, it's going to hurt, and we understand that. There's not really any way around that, but you can't sedate the patient daily for dressing changes because you run into many other problems when you're doing this, right? You're sleeping all day, you're not eating, you're not getting the nutrition you need, you're not getting the exercise you need, so we'll give pain and anxiety medications, but we won't always sedate the patient for dressing changes because we need the patients active, we need them up and about, we need them eating and interacting. It's good for their mental health as well, believe it or not. Sleeping all day is actually not good for you. Of course, you want to use proper protective equipment, hand hygiene. Usually you're going to use contact isolation on these patients because you don't want to cause an infection that you can prevent. You're going to remove the dressings carefully. Usually helps when you get them wet, so we'll do it in the bath a lot of times. And then they'll get their bath and reapply the dressings. All right. Pretty much what I just said. Okay. So basically you're going to assess, make a plan. This is a group effort, team effort. It's the surgeons, it's the nursing staff, it's the therapists. Everybody's involved with this. You're going to do your treatment, your dressing changes, you're going to evaluate, and then you're going to go back to the beginning and reassess and make a new plan. Are the grafts taking? Do they need more surgery? Maybe they don't need more surgery. Maybe the surgery went well, and we're just going to continue dressing changes. So this is a continual loop you'll continue to do until the patient's fully healed and ready for discharge. Signs and symptoms of infection are very important here, right? Because as much as we like to prevent infections, it still happens. Those bacteria are tricky. What are you looking for? You're looking for odor. You're looking for, is the graft actually taking? One of the reasons for graft failing is infection. It's not the number one reason, but it is a reason that they fail. Increased temperature, right? Running fevers, increased pain that you shouldn't have, swelling, redness, cellulitis, sign of cellulitis. A deeper, beefy red, as we like to describe it, is a great sign of infection that you're looking for. And then how do you treat that? Well, first you have to, general antibiotics can help, proper washing, all these things, dressing changes and washing. Those are actually the best way to prevent infection, believe it or not, better than antibiotics if you do really good wound care. But antibiotics help. Then you got to do tissue biopsies to find out what's growing, so you can treat with the right antibiotics. And then wound cultures, of course, for the same reason. All right, so now we're going to get into types of burn dressings. So these are soaks, and there's a, just an example of what's a soak. You're literally just pouring a liquid onto a dressing. These dressings are usually already on the patient when you're soaking them, by the way, but this is just an example here. And then, of course, we have ointments we can put on as well. Many different kinds of ointments. All right, a lot of them are Vaseline-based, which helps keep them moist. And then we have some biosynthetic dressings, which this was an old one called BioBrain, which I don't believe they actually make anymore, but it worked really well. So you're basically taking what would be a biological matrix and making a synthetic version of it. That's why they're biosynthetic. And they actually worked pretty well. They'll stay on for about a week while the wound heals up underneath. All right, so Remember, these are burn wounds that are healing on their own, so this is probably what I would consider a partial thickness or second degree burn or deeper second. This is a way to apply a dressing. This could be any type of dressing that stays on for about a week because there's tons of them that exist out there. You're going to clean the wound first, right? You have to debride. Remember, debriding can be done by anyone. It doesn't have to be a surgeon. This can be a nurse or a technician, whoever's cleaning and debriding the wound. And then you'll apply the dressing. And then you're going to usually apply outer layers to that initial product you put on the patient, usually with gauze and some kind of pressure garments to help hold it in place. You can use surgical netting, ace bandages as well. That pressure on the area helps hold everything in place where it needs to stay. All right, and after a while you'll see the change here with this specific dressing a week or so later, and then it starts to peel off slowly over time as it heals over the course of a couple weeks. All right. So what do you do with all these dressings you have on your patient with the exudate that happens, right? Burn wounds leak, especially the partial thickness burns. You have to be able to collect this, the leaking. Best way to do that, we usually wrap it in a bulky layer and some Kerlex to help hold it in place. And then that has to be changed on a regular basis, but the base layer you put on over the actual burn wound stays there. Usually these dressings are porous and allows the exudate to leak through. Okay. This is an example of our Silverimpregnated dressings that we use. We have many different brands and products, but thousands of years on this planet, and we've known about it for a long time. It's very effective at that. So you impregnate these sponges basically with silver. There's a special matrix on the bottom that goes directly onto the burn wound, and this one has an actual pad on top that helps absorb the exudate. So this is a really nice all-in-one dressing here. And then of course you're going to wrap it in place because it's going to fall off if you don't with Kerlex and ace bandage. And this is what you put over a partial thickness burn. You would let it sit for about a week, sometimes 4 to 5 days, depending on what the doctor wants. Reevaluate, and then if it's not fully healed, you can reapply a different one and give it another week. Okay. Remember, partial thickness burns usually take about 2 weeks to heal. All right, so here's some examples of the soaks I was talking about earlier. These you can soak the grafts, you can soak deep wounds that aren't grafted as well when you're trying to clean up a wound bed. So sometimes wound beds are just dirty and surgeons don't want to graft them, right? Don't want to graft a dirty wound bed, infection will prevent graft from taking. So in the meantime, you're basically doing wet to dry dressings on a large area. Well, how do you do that? Well, you're going to, believe it or not, the easiest way to do it is to apply a layer of gauze, then apply a bulky layer, and then you're going to soak it very thoroughly, and then you're going to wrap it up in an ace bandage and let it sit for a day and then change it daily. Or sometimes if it's a big infection issue, I've changed them as often as every 2 hours all day long. Just depends on how infected and how clean you want to get the wound. Remember, wet to dry. You're putting gauze directly on the wound, you're soaking it, you're letting it dry, and you're removing it. And it's that removal process that pulls away all the nasty stuff. And then you don't want to keep you can do a wet to wet, those do exist, but I don't think they clean as well. Because when you're re-soaking it and you're pulling it off, you're not actually cleaning the wound when you pull it off, right? You're leaving behind all that gross stuff that was there. And you don't want to do that to a fresh graft, right? Because you're ripping the graft off. That's why you don't normally do these wet to dry dressings on a graft. You'll do them on an open wound. Some of these soaks are very good antimicrobial coverage, silver again, silver nitrate, mafenide acetate. And they have some different antibiotic soaks as well. Sodium hypochlorite is also known as Dakin solution. We used vinegar, believe it or not, acetic acid. We use lots of different soaks that help. Dakin solution is very commonly used. It's great for cleaning. It is a very diluted 0.025% bleach solution. Obviously there's a few other things in there. It's not pure bleach. Please don't go to Walmart and delete bleach thinking you can use that as wound care. And there are more things to it than that. And it can be a little caustic to certain areas, so some solutions are stronger than others. and they can actually prevent skin cells from forming if it's a little too strong, so you have to be real careful with that. And I think it's only good for 24 hours after it's mixed. All right, so some ointment and cream dressings. Where are we at? Top 30 minutes, okay. Silver sulfadiazine has been very popular. That's Silvadine. Not used very commonly anymore, believe it or not, at least not in our hospital. Mafenide acetate, sulfamylon is used very frequently. It's a great antimicrobial, but it's very expensive. Mupiracin's a great ointment for staph. Then you have other antibiotic ointments. Obviously, triple antibiotic ointments are very commonly used. Antifungal, if you have actual fungus growing, which happens in burn care all the time. We use antifungal ointments, and we actually have antifungal soaks as well. All right, so targeting the burn wound, dressing should be wet, but not completely just dripping, dripping, dripping. You don't want to get them that wet. You just want to make them moist because you want to give them time to dry. And that's how they're going to work well. Try very, very carefully only to soak affected areas. You don't want to, you'll see this all the time. Somebody will soak an entire leg when there's only a small burn area on that leg. And then using silver nitrate, what does that do? It turns everything brown, right? So you have an entire brown leg when there's only a small burn on that leg. So try to only soak the affected area. You can also cause maceration of good tissue as well if you keep them wet all day long. You can also take these rubber catheters and place them underneath your dressings to soak to specific areas. You can get a 60 cc syringe, catheter tip syringe, and inject your soak directly into that rubber tubing. That'll put it right where you want your soak to go. It's a nice little trick sometimes when you have a hard to reach area. All right, 4 layers of soaks and ointment dressings. So you start with the wound. Your top layer is usually going to be a fine mesh gauze layer. And then on that fine mesh gauze, you'll rub in an ointment. And if you're soaking, you're probably going to add your fluffy layer next and then soak. The good thing about the fine mesh gauze with ointments, by the way, it helps hold your ointment where you want it to stay. If you just apply an ointment directly onto a burn and then throw a Kerlix on top of it, that ointment's not going to stay where you want it to. It's just going to get absorbed by the Kerlix. That's why we like using the fine mesh gauze and rubbing ointments into them. All right, so once you get the fine mesh gauze layer down, you're going to put a fluffy layer. You can put if you're doing soaks, you can put bulky gauze, wide mesh bulky gauze down. If you're not soaking, you're just using ointments, you can go straight to the Kerlix or the roll gauze, whatever you want to call those, to help hold it into place. Then you're going to soak if you're soaking. If you're not soaking at this point, you can go straight to the elastic bandage. But you're always going to put that on to help hold everything into place a little better, and a little bit of pressure is always nice to keep things where you want them. Also helps promote your lymph return and prevents venous stasis if you put a little bit of pressure on everything. Remember, distal to proximal, very important because you want good venous return. Always wrap distal to proximal from the end towards the center. And then never ever wrap starting mid up, right? Because you have all this area distally that has pressure, and you're going to have bad blood flow to this area if you're cutting off blood flow. So if you have a burn up here on your upper arm, you're going to wrap from your fingers all the way up the arm to prevent good venous return. All right. Of course, you're always going to look at cultures to see if anything's growing on wounds. Usually for larger burns and more severe burns. For minor burns, and if you don't have signs of infection, you really don't need to do a bunch of cultures. Just give it time to heal, and if it heals, then you don't have to worry about it. All right, topical dressings. Like I said, antibiotic antifungals exist. There's a nice picture of some Surginet, which is great for fingers. They come in different sizes. You can cover each finger individually with a little strip of the surgical netting after you put your layer of ointment on. It'll help hold it into place. And then, of course, that surgical netting can actually be applied everywhere. We've made face masks out of them. We've made underwear out of them. They're very useful because they come in different sizes. I've made shirts out of them, full-blown pants out of them for patients that needed them. And it's a very cool product. All right, another picture here of ointment dressings. You can see how it's actually rubbed into the fine mesh gauze in that first photo. And then that's applied directly to the burn wound, usually on partial thickness burns or over a fresh graft, by the way. They'll also do this, place over a fresh graft. Then they'll put the bulky gauze down over the fine mesh gauze, and then they'll wrap it in place with some kind of gauze roll. And then you can also add a little extra pressure, put an H-wrap on top of that if you like. All right, so sometimes you're going to get burned areas that aren't highly vascular. Cartilage of the ear is a great example. So this is you'll see a lot of infections form in these areas and tissue get necrotic here because you allow the burn to get worse. So how do you treat that? You need something that's going to penetrate into the cartilage. Sulfamylon is a great ointment that does this, okay? So you're going to see on burned ears and areas with cartilage, you'll see sulfamylon gauze applied to those areas because it helps penetrate a little deeper into the tissue than the other ointments do. Also, please don't put this on fresh graft because it will penetrate through the graft and cause it to fail. Okay, so if the ear is grafted, stop using this. This is for non-grafted ears, okay? And that's actually very important. All right, treating the ear and nose, so more cartilage in the nose, right? The same thing, you can put sulfamylon on the cartilage of the nose as well if you need to. And this is what you're going to do to help prevent infection, right? Once surgical intervention has taken place and grafting is done, you can stop putting sulfamylon on those areas. Enzymatic debridement is used. Sometimes you'll get a burn tissue that has some gunk built up on there you can't get off. There are some enzymatic debridement products out there that you can use. Sometimes they work, but they usually take a very long time to work. In my personal opinion, I think you're better off doing more manual debridement, surgical intervention, than waiting for the enzymatic debridements to actually work weeks down the line. But they have been shown sometimes to remove some necrotic tissue, some stubborn tissue you can't get rid of. That needs to go because remember, necrotic tissue is a source for infection. You want to get rid of it. And sometimes it is used in conjunction with surgery, but more often than not, our surgeons are really good and they're going to just surgically debride the areas that need to be cleaned. All right, Amnion. This is a fun product. Basically, it's from the placental sac. Exactly how it sounds, Amnion. Indicators for use, you're going to put them on usually partial thickness areas, which will allow, and this is literally the definition of a biological dressing, okay? It's not synthetic, it's actual biological dressing. It is expensive, and you have to keep it properly maintained, and you have to basically get the product, which I don't know the whole process behind that, but I know you have to, it involves a baby of some kind being born. Remember, we're not advocating bad things happen here. This is all legit product here. Some people say that these have stem cells in them and they help the wound to heal. I don't know the exact research on this. It's something probably that we should look into a little more to find if that's actually true, but it does make for a great synthetic dressing, or not synthetic, it makes for a great biological dressing to cover the burn wound, okay? You'll see them used on the face fairly frequently. They're put on the backs of a lot of patients as well, and they stay on for about 4 to 5 days as the wound heals up underneath. This is also considered a surgical procedure. This isn't something that's going to be done by nursing staff. This is going to be done by surgeons, usually in the operating room. So what is the ideal acute burn dressing? I've gone over tons of them, right? And I could spend hours and hours and hours talking about all the different burn dressings. Well, there is no ideal burn dressing. It's what works for you, what works for the patient, right? You have different options. You have options where you do daily dressing changes, right? If you're putting on ointments, change them daily. If you're putting on the Silverimpregnated dressings, they're staying on for a week at a time, right? So your patient's not from here. They have to go back home and be followed up in a week. What are you going to use? The dressing that stays on for a week, right? Or the patient or the parent who's taking care of our patients is comfortable doing daily wound care, you're going to use the ointments if they're happy with that, and they can do it daily at home. Or if they're an inpatient, it's up to the doctor's discretion what they want their patient to have. because the nurse will be doing the wound care every day for them. All right, well, remember, they always need to be followed up and made sure there's no signs of infection and they are actually healing. Right, so it depends, exactly. Make sure the wound's always clean before applying the dressing. Always assess, and it's continual assessment. Monitor circulation is very important. And then, this is actually a good point here, maintain web spacing, full range of motion. So what's web spacing? Spacing between fingers, spacing between toes. Why don't we just take a hand and wrap all the fingers together? All right, done, wrapped, right? What happens to that space in between your fingers when that starts to heal, if they're burned? They'll actually heal together, believe it or not. So it's very important to individually wrap fingers, individually wrap toes, and actually get something down in between them if there's burns there as well. Put a little strip of gauze with ointment or whatever you're using in between and the web spacings as well, because you want all that to heal without it touching other tissue, because it will heal together. All right, so you got the patient wrapped up, you have the wound care done for the day. What else do they have to do? Well, they have to live their life, right? They have things to do, ADLs. So we work in partnership with our occupational therapists and our physical therapists, and they're going to help a lot with positioning and splinting these patients. So what happens when my hand heals flat from third-degree burns covered in grafts in my hand, right? Well, you have scar tissue when it heals, and it's not very pliable like regular skin. And suddenly I can't close my hand. Well, I'm starving, but I can't even grab my hamburger to pick it up, right? So you want proper positioning like this. You're going to see splints made like this where the hand heals in this kind of configuration. And this is how they're splinted to heal over the course of, the weeks that they're healing. And then when it's harder to move, well, at least you have your pincer here that you can pick things up with. You can be more functional. And obviously, for the rest of their lives, they're going to have continual follow-up treatment, plastic surgeries to make their bodies more functional. Their kids are going to grow. They're going to have more scar contractures and things to deal with that need to be taken care of. So it's a lifelong process to keep them functional, and of course for cosmetic reasons as well. But you can prevent a lot of those issues from happening with proper positioning. All right, so develop a plan and execute a plan. Basically, what I've been talking about for chronic burn wounds. It's very resource intensive. You're going to have to do your treatments. You're going to have to evaluate the effectiveness of your treatments. And then you go back to the beginning and you repeat. Factors that are going to affect your wound healing, like I said, your ADLs, you have to be functional. You have to have proper nutrition. Anything over 30%, you're hypermetabolic and your body needs more calories than it normally would. You're going to have elevated heart rates during this time. Proper oxygenation. Without oxygen, your tissues aren't going to properly function. They're not going to heal. You need physical activity, right? Muscle atrophy is actually very bad. And if you don't get up and move, you're going to have muscle atrophy. So you want to prevent that by physical activity. Therapists are real good at getting kids to exercise, getting older patients to exercise as well. Age is a huge factor when it comes to healing of burns. The older you are, obviously, the more comorbidities you're going to have and the more issues you're going to have with healing. Children tend to heal very well, adults much less so. And then, of course, comorbidities, smoking and alcohol use is going to cause lots of other problems. You're going to have organ deficiencies, diabetes, and then obesity is also another issue that makes healing of burn wounds much worse, especially graft take, I've learned over time. High levels of stress are going to increase your enzyme levels and things like that, which can be bad as well. So, yeah, being in a hospital and being burned is stressful. You have to find ways to help relieve that stress. We have lots of different people who can help with that. Child life's great with that. Psychology will help with that. And then, of course, infection also we want to prevent. Now, you've treated patients. Some of them have had some third-degree burns. They've had some scarring issues. This is some ways that you can help prevent these issues from being severe, right? You're going to have some scarring with third-degree burns and skin grafting. It's just the way it is, but some can be worse than others. And with proper treatment, you can make them less severe. Pressure is a great way to prevent scarring from rising. How do you do that? Well, we have silicone strips you can put on places, inserts, moisturizing cream and massage is actually a really good one. That's a daily thing that we always teach our parents to do on the outpatients. Avoid sunlight. This is very important, especially until your pigmentation goes back to full color. And that can take, some people, that can take up to a year, believe it or not. Hopefully, if it's just a partial thickness burn, months is all you really need to wait, but it can be up to a year before you can really get exposed to good sunlight again. And even then, we recommend SPF 50 or greater anytime you're out in sunlight. And then if scarring gets bad enough, there are a lot of surgical treatments to help reduce the scarring. We have CO2 and other types of lasers that they can use to help reduce scarring. Like I said, lifelong procedures or lifelong management to people who have large third-degree burns. All right, so trying to create ideal conditions for burn wound healing, right? And like I said, I'm just scratching the surface here. There is so much more that you can do to burn wounds, and people who are in the field are going to learn. You're going to get real familiar with a lot of them. But you need to be knowledgeable, and honestly, how do you get knowledgeable? It takes experience and time. And everyone feels lost at first. The more you do it, the more you get used to it. Keep the wound clean, keep it moist. You don't want it drying out too much, unless it's a donor site. See, it's always there's always a what if or something there. Donor sites, you actually want them to dry because it helps them heal faster. Manage inflammation and infection. You want to prevent those from happening. You want to restore the patient's independence, and that's really important. That's what we do here. That's what we're striving to do, is to get the patient back to normal life. All right, be a patient advocate. Always do what's best for the patient, as I like to say. Sometimes you're not going to agree with something that's going on. Is it what's best for the patient? And that's what you're looking at. If you disagree with the doctor saying that's a horrible idea, it's going to be horrible for the patient. Advocate, right? Go to somebody who can get something done about it. We have time for some case studies.
Yeah, we have about 5 minutes.
Okay.
Questions?
All right, so quick case study. 3-year-old girl touched a hot stove, sustained burns to both of her hands and wrists. The burn was calculated to be 4%. Remember what I was talking about, third-degree burns? That definitely looks third degree. That is a deep red and looks like some eschar there. The parents brought the patient to the hospital. The patient is screaming and crying, and her hands are clearly swollen. So what are you going to do? What do you start off with? Medication's a great thing to do, right? It hurts. You want that baby to sit there screaming and crying the whole time? Absolutely not. And advocate for this patient. Doctor, I need some pain medication for my patient here so we can actually clean up these wounds. All right, that's usually step number 1. You're going to assess the patient. You're going to get an order for some pain medication, and you're going to clean the wounds, right? What do you clean them with? What's the best thing to clean any wound with? Anybody know?
Usually a steak on the unit.
Soap and water. Number 1. Yes, Dakins is also good, but the number 1 way to clean a wound is soap and water, believe it or not. Not antibacterial soap. No, you just want to use plain, non-scented, normal soap. Soft soap's great. And running water. That's the best way to clean it, and then you can follow it up with some kind of solution as well to try and kill off any extra bacteria lying around. Then what are you going to do? Evaluate, right? The doctor's usually going to come see the patient. They're going to decide what they want to do. Is this truly third-degree burn? If it is, it's going to need surgical intervention. Is it partial thickness? Well, if that's the case, you're going to put a temporary dressing on it, right? What are our options? So the parent says, oh, I got to go back home. I can't stay. You know, we live about 3 hours away. I can't come back for another week. What are you going to put on it? Are you going to put polymica on it and change it daily? No, right? You're going to put a longer lasting dressing. Tons of options, right? Well, that's what the doctor decides what to put on it, but tons of options for that. Let it stay on for a few days, and then see them back in a week and see what progress they've made. Or doctors say, oh, it's too deep, we need surgical intervention. This patient will probably get admitted to the hospital and have surgery and stay on in the hospital for a few days. Okay? Are there any questions that anybody might have right now? No? Okay. Thank you guys very much.